Welcome. Good evening. And I'm really very pleased to welcome you to the 5th annual Global Health Fair. I'm delighted to see that this one has become one of the most important events in our medical school and now in the Rutgers system. And I am extremely pleased to share the welcoming remarks with Vice President Rigolska from the Office of Global Advancement and International Affairs at Rutgers. My office and her office jointly sponsored this event. And before I introduce the speaker we have, the keynote speaker we have for today, I will ask Joanna to make a few welcoming remarks. So.
Good evening, everybody. My name is Joanna Regulska. I'm Vice President for International and Global Affairs at Rutgers University. And this is truly actually a very exciting moment for us. This is now the second time that we officially are working together on sponsoring Global Health Fair. And we are excited because there are so many wonderful posters. I just have an opportunity to walk around, not only from the medical side, but also from the other side of the aisle, the social, the political, the economic. And I think one of the strengths of this merger is really that we're bringing two very important sides together, and that is the expertise in the clinical and medical side, and also the social, the political, the humanities side of what is really very important issue, and that is the global health. My office, the Center for Global Advancement and International Affairs, is a university-wide office that is engaging in numerous projects, initiatives, helping to build partnerships, build interesting programs. We have numbers of programs for students in global health, especially surrounding the international service learning programs that allow students to do both academic work and provide services to the communities in which they are engaging. We do look forward to more of the initiative. I am thrilled to work with Xavier and many of the other colleagues. One of the initiatives that we have just launched is the agreement that we have signed with the Fulbright Commission in Brazil to bring a Brazilian scholar in global health. That scholar will be placed at the School of Public Health for the first school that we are joining in this agreement, and the scholar will be coming in the fall of 2014. This is all part of our effort on our theme. You might have heard that we organize every 2 years a particular theme. Now, the 2013-2015, the theme is global health with exclamation point, because that's the key to the global health as one of the most important really challenges, but also I think opportunities for us to engage. So this year we have over 100 events, many of them taking place in many of your schools' departments. We're looking forward to the next year, so this is not too early to start thinking what kind of activities you might want to engage in next year, and we provide funding for seminars, workshops, conferences, visits, exhibitions, film series, you name it, students groups, and numbers of other activities. So please look forward to our announcement, and in the meantime, check our website, global.rutgers.edu, where this and other health-related activities and programs are announced. So without further ado, thank you so much for joining us, and I'll turn back to Xavier and his team, with whom we've done really, I think, pretty good work. Thank you so much.
Thank you, Joanna. And this collaboration with you has been wonderful. And my feeling is that global health has become the glue that holds together many different Rutgers schools. So, we are very pleased, to say the least, to have the honor of welcoming Dr. Brian Strom, the inaugural Chancellor of the Rutgers Biomedical and Health Sciences, on his second official day at Rutgers to be the keynote speaker at this event. Dr. Strom joins us after a distinguished career at the School of Medicine at the University of Pennsylvania, where he has been on the faculty since 1980. He was there the George Pepper Professor of Public Health and Preventive Medicine and the Executive Vice Dean for Institutional Affairs. Something that I found on my own is that besides being the Executive Vice Dean for Institutional Affairs, he was the Senior Advisor to the Provost for Global Health Initiatives since 2007. So he's he's a member of our team. He did his internship and residency in internal medicine, and he became a fellow at NIH in clinical pharmacology at the University of California, San Francisco, and earned his MPH degree in epidemiology at the University of California, Berkeley. He had earned a bachelor's in molecular biophysics and biochemistry from Yale, and an MD from the Johns Hopkins University School of Medicine. His major research interest is in the field of pharmacoepidemiology, and he's one of the giants, universal giants in this field, and he's done wonderful global work in this area. The application of epidemiology or epidemiologic methods to the study of drug use and drug effects. As I said, he is a pioneer, the founder of this field, and particularly in using large automated databases for research. Since 2001, he has been an elected member of the Institute of Medicine of the National Academy of Sciences. And therefore, we are very, very privileged not only to have our own chancellor here, but to have a person, such a distinguished scholar, deliver this keynote speech for 2013. Brian?
And I was just going to congratulate myself on having learned the technology yesterday. So, well, thank you. It's a privilege to be here. Privilege to talk about global health, which, as you've heard about, has been something, and as you will hear more about, has been something that I've cared about now for many years. What I'm going to be talking about is global health, an imperative for a 21st century academic health center. And I'll first give you my definition of global health, because in fact, I think that differs in different circumstances. And certainly, I'm part of the Institute of Medicine's Global Health Roundtable, a Global Health Interest Group, and they too have yet a different definition of global health. Talk about why I say it's an imperative, talk about my own global health experiences and philosophy, review with you the Rutgers Mission, as recently as it's fleshing out in its strategic plan, the Rutgers International Mission as part of that, the Rutgers Biomedical and Health Science Division's Global Health Mission, and its strategic planning process that we announced and began yesterday. Talk about that is RBHS, the Rutgers Biomedical and Health Sciences Global Health Goals, and finally end with some thank yous to our hosts. So first, global health defined. This is a definition which comes from the Centers for Global Advancement and International Affairs, and is really a very standard definition of global health, and the one that has been adopted here at Rutgers as well. And that is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. So in many ways, I think what's important to me from global health is helping countries that need help, which is different than some people define global health, which is just any international experiences any place in the world. My own focus, again, is really focusing particularly on the people who we in the developed world can really help in the developing world. In addition, as part of that, it's important to realize that global health also includes clinical care, research, and education for U.S. immigrants, immigrant communities, and underserved U.S. populations. The U.S. is part of the globe. It used to be referred to as international health for that reason, and in shifting the focus from international health as a term to global health, it's really focusing as well on U.S. issues as well as international issues. And in fact, U.S. immigrant communities provide opportunities to develop clinical skills about cultural sensitivity and research programs as well, for example, comparison of U.S. immigrant communities with the immigrant's country of origin. As you'll hear about in a few minutes, one of the programs that we started, for example, is in Peru, where the largest population of Peruvians outside Lima is in Paterson, New Jersey. And the ability to be able to make international comparisons between Peruvians in Peru and Peruvians here in New Jersey is an enormously powerful research tool to begin to get at the issue of nature versus nurture, and to what degree things are genetic versus environmental. And certainly here in New Brunswick, Mexico serves exactly that same opportunity. So what is the imperative for global health? I think there's a social, moral, and I'm going to talk about each of these separately. A social, moral, and ethical responsibility for institutions to be involved in global health. I think it's desired by faculty and students. It also brings faculty and students together across multiple schools, centers, and institutes, and departments, as we heard about in the introduction. So first, social, moral, and ethical. High-income countries, 7 out of 10 deaths are among people aged 70 and over. People predominantly die of chronic disease. Lower respiratory infections remain the only leading infectious cause of death. And only 1 in 100 deaths are among children under age 15. In contrast, in low-income countries, nearly 4 in every 10 deaths are among children less than age 15. Only 2 in every 10 deaths are among people age 70 and over. People predominantly die of infectious diseases and complications of childbirth due to prematurity, birth asphyxia, and birth trauma are among the leading causes of death in newborns and infants. So a very, very different picture of health problems in these two worlds. Another way of looking at that is in terms of life expectancy. If you look at a low-income population, life expectancy at birth in 1990, low-income population had a life expectancy of 52 years, and in a dose-related way, high-income countries had a rate of expected life expectancy of 76 years. 2011, now 11 years later, low-income countries had improved to a life expectancy of 60, where high-income countries had improved to 80. Still a very large difference. Somebody born in a low-income country has a life expectancy 20 years less than somebody born in a rich country. Looking at this in a little bit different ways, let me show you this density equalizing cartogram for all causes. Now, what density equalizing cartograms are maps, obviously, but where traditional maps weight countries based on geography, density equalizing cartograms weight them based on something different. So in this one, I show you mortality in 2002. As you can see, there are certain countries like India, like China, that are disproportionately high in their annual mortality rate. But it's sort of roughly equivalent to the geographic map that you'd expect to see. On the other hand, in response to these, people came out, the UN came out with the Millennium, Looks like we've got looks like we've got an older version of it. So, okay, sorry, my cartoons are missing. But we'll talk without them. If you look at non-communicable diseases, the diseases of chronic disease in 2002, again, you see roughly that same population, that same distribution, only if you look in countries like Africa, instead of it being large, disproportionately large in terms of total mortality, if you look at non-communicable diseases, chronic diseases, countries like Africa are disproportionately small in contrast. Now that has changed in the last decade or so. But certainly, non-communicable diseases are the primary causes of death. The U.S. has gotten larger compared to total mortality, where Africa has gotten smaller compared to total mortality. If you look in contrast to infectious diseases, infectious and parasitic diseases, there's a dramatic difference in picture, where the U.S. and the whole Western Hemisphere essentially disappears in terms of deaths from infectious and parasitic diseases. And now you have this explosion of size of Africa, India, and South Asia in general as part of that. So hopefully a dramatic visual demonstration of this great inequity when you're talking about infectious disease, infectious and parasitic diseases. And again, over the last 10 or 20 years, that's beginning to change. The irony is it's not that deaths from infectious diseases have dramatically dropped in the developing world, but that death from chronic disease, from non-communicable disease, has dramatically increased in these countries as the impact of the smoking-related epidemic takes effect in these countries. So when the tobacco industry suddenly couldn't sell cigarettes as much and as easily, first in the US, then in Australia, and then the rest of the developed world, they went and are marketing very heavily in the developing world, particularly to kids. And now, two decades later, we're beginning to see the diseases you'd expect from tobacco, increased rate of death from heart disease, increased rate of death from lung cancer, and so on. Again, from this social and economic phenomena. Oh, there it is, just out of order. Sorry, so it's the medium version. So this is, which I mentioned the WHO Millennium Development Goals. It's nice for the UN to tell people in Africa that's the goals, but there's no way they're going to get there. On the other hand, some don't have the strength to bicker about healthcare. If you look at our newspaper and our newspapers and us arguing about Obamacare, much of the rest of the world, they're starving. That's not a luxury they can worry about. And lastly, these are supposed to be mixed in, global threat waiting area, another ethical imperative in terms of global health. There are a lot of major issues, including the obesity epidemic that you find overseas. And ironically, you find both obesity and malnutrition in the same individuals. So people are obese because they've taken too many calories, but they're malnourished because the calories they're taking in are incorrect. And so the enormous differences, again, due to social phenomena. In the meantime, there are issues, for example, of bird flu, global warming, one of the ethical imperatives. And one of the ways it's really been sold to be of interest to NIH and to developed world government bodies is this issue of that's where global threats are coming from. Whether you're talking about bird flu, whether you're talking about whatever the issues are, global warming, which is being driven to a large degree now by China and the development in China, the developed world is beginning to suffer from the problems of the developing world, or problems that come from the developing world. Well, desired by faculty and students. I can tell you at Penn, it was one of the things that even though our global health program realistically wasn't that strong, so I don't want to give you the wrong impression, despite the fact that it wasn't that strong, it was the number one thing sold to applicants to the medical school in terms of people being interested in it. Here at Robert Wood Johnson, 16% of the class of 16 were born outside the U.S. 21 different languages are spoken by current students. Over 30% of the class of 2016 participated in study abroad programs before coming to medical school, and over 40 medical students went abroad in 2011, 52% of them first-year students and 48% of them third and fourth-year students. So a dramatic evidence of increase among the medical students here at Robert Wood Johnson. There's also a significant increase among the faculty. Xavier, as we just heard from, and the Global Health Steering Committee that is listed here, and lots of other faculty that are interested in it as part of that. And I'll talk a little bit later about the implications of that to our strategic planning process. Brings faculty and students together. Examples, this and the next few slides are examples of faculty-led projects with the potential to involve students. And there are many, many, many more than these. These are just a few examples to give you the sense of diversity. This is from New Jersey. These are from New Jersey Medical School. You can see in terms of TB in these countries and cleft lip and palate deformities in Bangladesh. These are examples from the College of Nursing and the Robert Wood Johnson Medical School, and these Dominican churches in the Northeast and the Dominican Republic, Spain, Colombia, and Argentina here, Javier's work. These are examples from Robert Wood Johnson in terms of Environmental Occupational Health Sciences Institute right nearby, and the Institute of Health Policy and Aging, again, Thailand and Mexico as the countries. These are examples, again, for environmental and health sciences, and the School of Environment and Biological Sciences in China, Thailand, and the Philippines. And lastly, from the Center for Global Health and the School of Public Health in Mexico and Uganda. Just a small sampling of just a few of the projects that are underway, focusing on global health among the faculty here at Rutgers. Well, what about my own global health experiences and philosophy that come out of that? I was one of the founders of the International Clinical Epidemiology Network. This was a program funded by the Rockefeller Foundation years ago, created initially in 1979. We were a founding member, one of 5 initial training centers. We established a training program 2 years full-time. The first year at the training center, the 5 centers, by the way, were we and University of North Carolina in the U.S., Toronto, at University of Toronto in Canada, McMaster also in Canada, and the University of Newcastle in Australia. We chose people ultimately for 1 year on site, 1 year back home. We learned that by experience. When we kept them for 2 years, they didn't go back home. And our goal was not brain drain. Our goal was to train people who are going to go back. So we kept them for a year, didn't give them clinical privileges while they were there, designing a project that they would do when they then returned home. For the second year, conducting the project, they didn't get their degree until after they finished the project back home. During phase 1 of INCLIN, it led to the development of 26 clinical epidemiology units in Latin America, India, Africa, and Southeast Asia. Our goal was to choose what we thought were the 26 best medical schools that did not have a school of public health attached to them, and give them enough of a critical mass of faculty. So for each of them, we trained 9 faculty, 6 clinical epidemiologists, clinicians trained in epidemiology, 1 social scientist, 1 health economist, and 1 biostatistician, with the idea that there'd be 9 people who could work together as a critical mass, forming a clinical epidemiology unit when they went back. And then the best of those centers were chosen as training centers of their own right, and they metastasized. They did the same thing. They chose offspring centers the same way we had chosen offspring centers. And ultimately now there are, without doubt, more clinical epidemiologists in Thailand than there are in the US. Thailand also chose centers, the Thai centers. They also chose centers in the Malaysia and other countries in Southeast Asia. So there became Asia Clen, India Clen, Latin Clen, so they all formed networks of their own. Ultimately, there were 63 INCLIN trainees that we trained at Penn before the second phase, where the offspring centers became training centers themselves. This gives a sense of the International Clinical Epidemiology Network, now 1,700 members, 34 countries, 82 clinical epidemiology units scattered all over the world. To the credit to the Rockefeller Foundation, this was run on a $5 million a year budget. They pulled all that off. Now, they were tough negotiators, I can tell you, which is part of why that happened. But they accomplished a lot, and many of these units still exist. Many of these people are now ministers of health and leaders in their countries accordingly. Other experiences at Penn. One is the Botswana University of Pennsylvania partnership. This was started in 2001 in collaboration with the University of Botswana. Botswana is a country wealthier than much of the rest of Africa because it has diamonds and it has a stable population. But what it also had was what it thought was 35% of the population HIV infected. In fact, that was misleading data because they didn't have epidemiologists involved. They did their survey among women who are childbearing, obviously a group more likely to be, because they're pregnant, they're also more likely to have HIV. But the point is, it's still a very, very high rate. It wasn't 35%, but it was very high. And in fact, the diamond manufacturers there would hire 2 people for each job so that one could take over when the other died. And the major social event in the country was funerals. It had an enormous impact on this country, which, having resources, decided to provide treatment for its HIV population prior to PEPFAR, the US program of PEPFAR existing. On the other hand, they didn't know how. So they first contacted our infectious disease department to help them provide the care. Then over time, we trained medical residents for them so that they could provide the care. We then helped them develop a medical school because they didn't have a medical school in the whole country. They sent their medical students out to other countries to be trained, and 90% of them never came back. So we helped the University of Botswana establish a medical school as well, which is now underway. And so it started as clinical care. Over time, we added bilateral exchanges, global health experiences for our students and faculty. Now there are literally hundreds of Penn people each year in this very small country. It has a population of just a very few million, smaller than Philadelphia, much bigger than Philadelphia geographically, smaller than Philadelphia from a population point of view, but hundreds of people from Penn are there each year. And many research programs focusing, as you'd expect, primarily on HIV, but also now on TB, as TB has become a big issue with the HIV epidemic, and cervical cancer and other things, all of which surround the HIV epidemic. So just a couple of pictures from Botswana. Another example, the Guatemala-Penn partnership that was launched in 2004. This is in collaboration with 2 very, very different schools. One of them one of them is University of San Carlos in Guatemala City. This is a massive public institution, hundreds of thousands of students. It's even bigger than Rutgers. Which is an accomplishment. Campuses over the entire state, or over the entire country, very, very left-wing, often on strike. The pictures of Che Guevara and Castro every place. Unlike Botswana, which has a shortage of physicians, Guatemala has no shortage of physicians. The medical school there at University of San Carlos takes in a class of 750 students each year. They graduate 250 students each year because that many don't pass. They have a first-year class of 1,500 students. How can they have a first-year class of 1,500 students if they only accept 750? Because of all the people repeating it. So they have plenty of physicians. Quality physicians are a different story. So in response to that, a new university, University of Francisco Marroquin, was formed in the early 1970s. This is a university which is completely the opposite. It is completely right-wing. They pray to Milton Friedman. You give talks in the Milton Friedman Auditorium, their equivalent lecture hall. It's the Milton Friedman Auditorium with a stock ticker going along the top the entire time. It started essentially as a business school. It is just professional schools. The medical school takes in 50 students, graduates 50 students. Its goal is to train the medical elite of Guatemala. It's only been around since the early 1970s, but it's already happening. These 2 universities despise each other. They won't talk to each other unless we're there. We actually got them to work together. We actually got them to invite board members to each other, only when we were there. And now talking about a partnership of these three universities that my hope is to bring Rutgers in as a fourth university as part of that, to establish a partnership across Guatemala. We also have a rural site, Hospitalito Aretlan, in Lake Aretlan. Just to give you a gestalt, this is a hospital of 18 beds. It is a referral hospital for hundreds of miles. So you have this city with this huge concentration of physicians, and the rest of the country that is none. And so we provide much of the care in the Hospitalito Aretlan because all the docs from Guatemala City don't go there. It is also a beautiful rural site where the people of Guatemala the rich people of Guatemala City go to vacation. So it's a wonderful place to send students. Unlike Guatemala City, which has a big crime problem that we'll talk about in just a minute. We have research underway there now, and I'll give you just a little bit of an example, and educational programs and other global health experiences going along with that. Well, what is we talked about the major public health problem of Botswana was HIV. The major public health problem in Guatemala is violence, particularly firearm violence. They had a civil war underway for 36 years that we funded, not we, Penn, but we the U.S. government. And it finally ended when there was a front page of the New York, most of the massacres were done by the government, by the military. It finally ended when there was a picture on the front page of the New York Times of a massacre of 1,000 people in Aretlan, where we now work. That finally called an end to the Civil War because the U.S. stopped funding it. But with that, the firearms are still there. And because of the fear of the government is kept weak and small, and as is the police force, as is the army. The net result is crime is an enormous issue. There's essentially no jurisprudence system because for years, for decades, the country was basically run by decree of the military. So there's no legal structure. There's no to speak of. There are entire parts of Guatemala City that even the military and the police don't dare to go into. There are other parts that are completely safe, but you have to know where you go and where you're not. It's not random violence, and it's not drug violence. The issue is if you get into a fight with the wrong person, you've got two choices. You get shot or you emigrate. And 1/3 of the Guatemalan population now lives in the U.S. in response to this. So Philadelphia is not a nonviolent city. They have more shootings per day than Philadelphia has per month. But yet, if you go out, if you look at the per capita death rate from firearm violence in Guatemala, it is greater than in Iraq or Afghanistan, greater than war zones. But yet, if you go outside Guatemala City, it is less than West Philadelphia around Penn, which shows you how much higher it is in Guatemala City in order to have that average. An enormously high rate of violence. And so that is the problem that we attempt to address. Our leader in the Guatemala program, his focus is firearm violence. We have research underway focusing on the Civil War, done by our trainees. 1 in 5 people in Guatemala have had someone injured or killed, mostly after the conflict. The post-traumatic stress disorder is higher than any other developing or Latin American countries. And exposure to violence, particularly for indigenous Maya, means significant increase in depression in the country. These are findings by one of our trainees. We had two grants from the Fogarty Institute to train Guatemalans using the same model we used in Inclin. So they spend 1 year with us, and then 1 year when they go back, getting their degrees when they go back. Our first trainee focused on firearm violence and the mental health implications of the violence from the Civil War. So this is a picture of the group of us at Francisco Marroquin, and this is just a few other pictures this is Hospitalito Aretlan. This is by the way, the old Hospitalito got knocked down by a mudslide. After spending millions of dollars to build a new one, it then got destroyed within a year by a mudslide. This was what they used temporarily as the hospital. This is the new hospital. built in a different area, not subject to mudslides. You know, it's a saying, fool me once, fool me twice. It's third partnership, to give you a sense, is the Penn-Peru partnership. This is the newest of them. This was formalized in 2008. It's a collaboration with Universidad Cayetano Heredia, private, small, essentially medically oriented elite university. So similar to Francisco Marroquín in Guatemala. Activities include medical student and faculty exchanges, clinical service, and research with extramural funding and pilot funding as well to stimulate the partnership. So our goal, this is again a very different country and a very different situation. Francisco Marroquín is a very high-class, intellectual high-class university. When we talked about, keep in mind, Botswana, the model was they don't have any docs. We train docs. Guatemala had a surplus of docs, but they had no research underway. They didn't know what to do with care other than try to copy what we do, which of course we can't afford. Why should we think they can afford it? And so we were training them to do research. Peru is in a very different situation. They have an entire research building. When they get an extra $1 million, they build a floor on their research building. Just to give you a perspective, Penn just built a new research building. It was $150 million. For $1 million, they build a floor in a research building, and they equip it with hand-me-down equipment from the north. But with that, they can independently compete as principal investigators on NIH grants. They're good enough to do that. They're probably the world's best place in tropical medicine, certainly much better than Penn is. And altitude medicine as well. Their major public health problem is maternal child care, particularly for people who live in the rural mountains and have migrated to the city of Lima. So these are very respected researchers with whom we really need to be collaborators. When we offered to put in a Fogarty grant to train them, they turned around and said, we don't want to be a trainee institution, we want to be a trainor institution. And they applied competing with us, competing against us with a site in Africa. So they're very high level, and our goal was to create a series of pilot grants to partner Penn faculty with Cayetano faculty in ways looking for opportunities where neither of them could do it by themselves, where they're treating both sides as equals. The Cayetano people couldn't do it without the Penn input. The Penn people couldn't have done it without the Cayetano input, where they bring different science, different technology, different issues. So these are not Penn projects done in Peru. These are really collaborative projects across the two countries. So three very, very different experiences. And it's just our partnership there and the leader of the partnership there. So what have I drawn from this in terms of my own biases, which presumably you'll see some of as RBHS develops its global health program? I think global health engagement really needs to be done as partnerships. Focusing on the needs of the developing world partner rather than on the preference of the developed world partner. You need a different program in different countries because their needs are different and their focus is different accordingly. I think in focusing on, historically, U.S. academic health centers have focused on infectious diseases in developing countries. We don't have infectious diseases much here anymore, other than now HIV, and that epidemic is more in control. And so global health has been the way we provide infectious disease experiences to our students. I think that's the wrong way to do it. I think the more appropriate way to do it is in partnership, focusing on the needs, again, of the developing world partner rather than preferences of the first world partner, with increasing recognition, and especially with increasing recognition that the historical focus on only infectious disease, and especially HIV, is misplaced. Because as their infectious disease epidemics are decreasing, chronic disease epidemics are increasing. I think it needs to, again, be done jointly with the institutional partners, identifying the specific problem and issues of importance for each site, and then bring to bear depth and talent to address these local problems. Engaging as many schools as possible, focusing on research, education, and service across all schools. This isn't just a site to give clinical care. This is a site to be able to really help in order to help address their problem, and in order to help address their problem. We need to mobilize all of what a university has to bring, not just medical schools. And finally, building infrastructure and sustainability at each. Because eventually, if we're doing our job, we should be evolving into true partners, like we became in Peru. Again, I give you the Botswana experience to show you the opposite, where they didn't even have a medical school. The idea is build them a medical school, let them be able to develop their own physicians, let them give their own care, let a subset of those then become researchers, like we're doing in Guatemala, and eventually become partners like they're in Peru. So if we're doing our job, we in the developed world become unnecessary because we're building infrastructure there. And in everything we do, it shouldn't be just a question of providing assistance. It should be looking to develop infrastructure. Let's talk about the Rutgers Mission. Rutgers Mission is providing for the educational needs of New Jersey's people through its undergraduate, graduate, and continuing education programs. Conducting cutting-edge research that contributes to the health and environmental, social, and cultural well-being of the state, nation, and world, as well as aiding the economy and supporting business and industries. And performing public service in response to the needs of the people of the state and their local, county, and state governments. Rutgers has 5 academic themes in its emerging strategic plan that was just presented a couple of hours ago at the Board of Governors. One of them is ethnicity, diversity, and migration. Second is creating a sustainable world. Third is health and wellness in individuals and populations. Fourth is educating citizens for a dynamic world. And fifth is creative expression and the human experience. With that as background, the Rutgers International Mission was enunciated by Bob as ensuring that our students are fully equipped to address the global challenges of our time as part of our university's mission of teaching, research, and service. Rutgers continues to provide comprehensive international programs, establish strategic international partnerships, and provide quality services to the international members of our university community. So the Rutgers International Mission includes to advance and promote global awareness and citizenship by engaging faculty, students, and staff in international studies, research, and initiatives that benefit New Jersey, the nation, and the world. The goal is to pursue its mission of excellence in international research, teaching, and outreach. Rutgers University will create an environment supportive of internationally and globally focused research, provide opportunities for graduate and undergraduate students to participate in a wider range of internationally focused educational opportunities, domestically and abroad, enhance undergraduate student skills in a way that will enable them to become accomplished and successful global citizens, to facilitate international and cross-national collaborations and partnerships, to advance and promote international awareness of faculty, students, and staff, and to increase the university's presence and recognition globally. So how does that tie in with RBHS, with Rutgers Biomedical and Health Sciences that I have the privilege as of yesterday to lead? My own view is the global health mission and strategic planning process the global health mission will emerge from the RBHS strategic planning process that I began yesterday. It'll include education, research, clinical service, and public health initiatives. That global health initiatives will focus on partnerships and assistance to developing poorer countries, for reasons I described earlier. The RBHS strategic planning process will begin soon, that is yesterday, and include, firstly, a survey to RBHS faculty, staff, students, and community people as well, to obtain information about the goals, their goals, recommendations, and how the goals can be achieved, and the resources needed to achieve it. That'll be followed, this first survey, which we have a draft of already, will be followed by a survey in January to Rutgers faculty, again, Rutgers faculty, not just RBHS faculty, but faculty all across Rutgers, asking them to identify their interest and expertise in potential areas of excellence. One of them, I can guarantee you, will be global health as their focus. And then we'll establish working groups to identify specific signature programs and the infrastructure needed to support the current activities and the signature programs. The strategic planning process, the RBHS strategic plan, that will then be integrated into the Rutgers strategic plan and be implemented beginning July of 2014. So finally, just some comments on the RBHS global health goals. My own views is that the RBHS global health programs will strive to address the imperative that I described in the beginning by making concrete and sustainable contributions to the health of selected, less developed countries, to develop long-term and sustainable programs with a broad base of faculty and student involvement and diverse financial support. To identify, it will identify Rutgers faculty who can be nurtured into leaders in global health. You already have some. We will identify through the strategic planning process other people who are interested in global health as well, who might not have participated in the process, joining them all together in these working groups to plan what the global health can look like in the future, and create opportunities for engaging Rutgers students in global health programs. Again, many places in the world, but particularly focusing on the partnership areas that we end up deciding on. My feeling is that the global health programs will address its public health mission by engaging the international community in healthcare solutions, by creating new and better ways, by improving health outcomes, by creating new and better ways to provide healthcare. So, we can't just copy what we do in the US. As I mentioned before, even we can't afford it and need to come up with new models. Developing countries tend to learn here and copy what we do. That is a very bad message and a very bad, they need to be able to figure out what is right and what is the best way of expending resources in their own environment. Our global health programs will address their educational missions by preparing students for life in a global society, by expanding educational opportunities and experiences, by providing international educational program sites, and by recruiting and retaining students, whether undergraduate, graduate, or professional, and faculty with global health interests, and by enhancing Rutgers' reputation internationally. We'll address our research mission by promoting innovation and the development of new research strategies and methods, by providing U.S. immigrant communities and international sites for comparison for research, by providing opportunities to conduct research on rare and/or emerging diseases that are not found in the U.S. but will be found overseas. As I alluded to, Peru. I walked the halls of the hospital in Peru and saw multiple cases of diseases there that I had never seen in my entire clinical career here in the U.S. And expand research opportunities through the development of international partnerships, and enable faculty to create new lines of research by taking advantage of funding opportunities. My goal is that the RBHS global health programs will address their service mission by increasing opportunities for service, by sharing knowledge with the international community, by creating global partners and promoting interactions with them, by building capacity here and at the international sites through bidirectional activities. Again, very important, it's bidirectional. It's not just sites for our students to go overseas for medical tourism. We want people to be able to come here as well so they can be learning in both directions. And that learning in both directions works at both sites. Having international students here will educate our students, and having Rutgers students overseas will educate their students as well as our students. That bidirectionality is critical, as well as more equitable, and enhancing international diplomacy. As I alluded to you, ironically, that two Guatemalan institutions wouldn't be in the same room except when we were there. That global health, my goal is that our global health program will enable students to learn of other healthcare systems, interact with other cultures, and practice and master other languages. That they'll learn to provide culturally sensitive care to diverse populations, including those in the US and New Jersey. For example, the New Brunswick Latino immigrants that we mentioned before, primarily from Mexico. They'll sharpen their clinical skills if appropriate, because there are all sorts of things you can see overseas that you can't necessarily see here, and gain an understanding of cost-constrained, limited resource care and the importance of public health and delivery of care as well. And finally, to advocate for the needs of the underserved and stimulate interest in global health careers in the process. So finally, let me end with a thank you to our hosts. Firstly, comments So typically brilliant of you to have invited an epidemiologist. I'd like to thank the Robert Wood Johnson Medical School Office of Global Health, Xavier in particular. Here's their website to get more information about what its program is. I'd also like to thank the Centers for Global Advancement in International Affairs and Joanna as part of that, and again, their website as part of it. It has been, and thank you as well to the hosts for the biennial theme of global health with the exclamation mark as part of it. These centers bring together the entire Rutgers community, as you heard, and focus activities around a unifying biennial theme, recognizing that global engagement depends on a collaborative and multidisciplinary approach. That theme for these years, as you heard from Joanna, is global health, which aims to bring together the strengths of the humanities, social and life sciences, business law, economics, education, and the healthcare professions to address today's global health challenges. Hopefully in some of the examples I've shown you, you can see how and why that is needed. Global health is much more than physicians going and traveling and delivering care. My urge to you is get involved, participate in the participation, advance our knowledge about global health, participate as well from an RBHS point of view in our strategic planning process. So I'll conclude with just some pictures. The prior ones were from my own experiences. This is from Rutgers experiences. Here, this one actually that's from Guatemala. That's also Guatemala. That's San Carlos. This is Aratlan. This is the library we set up at the University of Pennsylvania, set up in this little hospitalito Aratlan, and we maintain remotely. So they have access to this hospital of 18 beds, has access to everything at the University of Pennsylvania's library via remote access. And then these are some pictures. Again, this is from Guatemala. This is Francisco Marroquin, and some typical Aratlan pictures. Cute kids who these people did give consent for the pictures. Let me be clear about it. And let me end with that. Thank you.